Okay, so today's disease is about inflammatory bowel disease, and there are two. There are two important IBDs that we have to talk about. One is UC and the other is Crohn's. UC is ulcerative colitis. Now, Crohn के अंदर there is no particular name of the intestine, so it's from the oral cavity to the anus, anywhere. But because UC has the name ulcerative colitis, it is definitely involving the colon. Okay, it definitely involves the colon, and it is a continuous involvement. Okay, so it is a colonic inflammation plus continuous. That's very important. But here you could see skip lesions. Okay, and usually the rectum is spared. But note, in ulcerative colitis as well, from the colon it can lead to an ileum backlash. Okay, it can enter the ileum as well. So it's not necessary that there's an ulcerative colitis can only have a colonic involvement. Definitely not. You could also see ileum involvement. You cannot just make a direct diagnosis on that basis. So that's another important point that I had to make. Now, when I'm talking about epidemiology, the Crohn disease, the Crohn disease is more common than ulcerative. So Crohn is more common than ulcerative or UC. And in UC, the males are more commonly affected than the females, but in Crohn's, the females are affected more than the males. Why? Because of the use of OCPs. That's a very important thing. What about smoking? What does smoking do to UC? Okay, in UC and in Crohn, if you know, Crohn is worsened by smoking, but UC is protective. And what about an appendectomy? Well, an appendectomy is protective again in UC, but it's going to have no effect on Crohn. So removal of the appendix, correct? Removal of appendix. If you take antibiotics in the first year, increased risk of UC. If you take antibiotic in the first year, again increased risk of Crohn's. Simple. Okay, that's a very important point that we had to speak of. The associated genetic syndromes that are with Crohn or UC. Turner syndrome is with UC. Wiskott-Aldrich is with UC. Wiskott-Aldrich is associated with UC. Whereas with Crohn, you have Turner again. We have glycogen storage disorder 1. And we have something called as a Hermann-Podack syndrome. Hermann-Podack syndrome. Correct. What is the Hermann-Podack? You know about glycogen storage disease like von Geerk's. But what is Hermann-Podack, if someone asked you? It's a disease where you can see granulomatous inflammation. You can see platelet dysfunction. You can see pulmonary fibrosis, and you can also see oculocutaneous albinism. Correct? You can see a granulomatous colitis also because of the granulomatous inflammation in this Hermann-Podack syndrome. Again, Hermann-Podack. Turner is common in both. In UC, you have the Wiskott-Aldrich. In Hermann-Podack, you have the Crohn. Similarly, in the GSD, the Crohn. And one more disease is IPEX, which is seen in UC. Okay, IPEX. And this is a syndrome where there are polyendocrinopathies. So you could have a thyroid disorder, you could have a DM1, you could have non-granulomatous disease. Okay. Genetics of Crohn. Okay. So the genetics of Crohn's is simple. It's associated with NOD2 gene. And there is a defective innate system. There's a defective innate immunity. There's altered gut flora, which is causing all of this. And UC is actually associated with HLA DR1 and DR3. Okay. Well, this is not really asked that what causes UC and what causes Crohn's, but I thought of mentioning NOD as an important distinguishing factor because ulcerative colitis is involved with HLA. Okay. And Crohn would also be involved with defective innate immunity, as I've already spoken, and overactive adaptive immunity, which is causing increased inflammation, correct? Because Crohn disease itself, okay, it has a lot of granulomatous inflammation. So that is why any disorder where there is an increased adaptive immune response can lead to Crohn's. Let's talk about the path. Okay, let's talk about the pure pathology of ulcerative colitis. Okay, we're talking about UC here and Crohn's here, just to maintain the differentiation. UC has the limited region involvement. It cannot involve the entire thing. It can involve the rectum. It can involve rectum, even the colon, and it can cause pancolitis, and it can also cause backwash ileitis if it goes up into the ileum as well. That's it. What you will have as a finding is going to be bleeding, but before that you would also have a erythematous mucosa, red mucosa with granular surface, later forming an ulcer. Okay, later forming an ulcer, which would healing to form something called as a pseudopolyp. Also, because of this healing, there is going to be shortening and narrowing of the colon. Shortening and narrow colon. So it's going to give a lead pipe appearance. Okay, it's going to give a lead pipe appearance. And because it involves the lower part, it's going to present with tenesmus. It's going to present with blood streaks. It's going to show slow transit. And the bowels are also going to be less frequent. Okay, the frequency is not going to be much. But compared to a small intestine disease, definitely it's not going to be much. Okay, so that's the rule, as we all know, that the small intestine, if it's a small intestinal involvement, okay, the frequency of passing stools is lesser. Okay. A very important point that I wanted to make, I'm sorry, if it's in the large intestine that is involved, the frequency of passing stool is going to be higher than the small intestine that's going to be involved. A very important point that must be made is that on microscopy, okay, I do not see no granulomatous inflammation. Now I'm saying this straight off the bat because in IPEX there is no granulations that are seen, no granulomatous inflammation. So when I tell you that ulcerative colitis is non-granulomatous, you have to think of diseases that could be associated with ulcerative colitis, but they have to be non-granulomatous. Okay, so that's one very important finding, microscopic finding. Another very important finding is that the crypt architecture is lost. So the crypt are lost. And the basal cell and lymphocyte aggregates are seen. They are seen, okay. Also, we see Paneth cell metaplasia. Paneth cell metaplasia may be seen. But that is about it. Now, coming to the Crohn's disease shows a complete involvement of any part of the GIT, any GIT as whole, from mouth to the anus, completely. But the most common is ileocolitis. Okay, the most common is ileocolitis. That is the ileum and the colon being involved. And obviously, there are skip areas that are seen. Correct. And these skip areas, okay, they begin. How do they begin? Well, they begin as a small aphthous ulcer. It begins as a small aphthous ulcer. And these ulcers, then they fuse longitudinally and transversely. Okay. And when they start fusing these serpentinous ulcers, they form something called as a cobblestone pattern. Also, we see creeping fat. Because there is strictures that are formed because of this entire cobblestone patterning of the Crohn's disease. And what do you see? What do you see on the patient? What the patient presents as? He presents as abdominal pain. Also, it presents as the pain that betters with diarrhea. Pain betters with diarrhea. That's a very classical finding with diarrhea. So every time they do pass feces, the pain becomes better. Also, there is steatoria that can be seen, weight loss, lymphadenopathy, because it can involve literally any part of the intestine, and if it involves the ileum also, you can obviously see certain amount of steatosis, fat being lost. All right, so what next after the cobblestone and the creeping fat pattern? What are the microscopic involvement of the Crohn? Well, the Crohn is a transmural involvement, so that means all layers are involved. Okay, and we have non-caseating granulomas. So now non-caseating granulomas is not necessarily only not it's not necessary that caseating granulomas are seen only with TB. So TB can also lead to a non-caseating granuloma, just in case. So you should keep that in mind. Also, you can see crypt abscesses. In ulcerative colitis, crypt architecture was lost. Okay, no lymphoid aggregate. That's very important. And pyloric metaplasia may be seen, and I think that's about it. So in clinical features of ulcerative colitis, okay, now again talking about the ulcerative colitis that we have. If someone asked you what are the clinical features, you have to say obviously there's going to be proctitis, fresh bleeding, okay, large bowel diarrhea, a lot of stools. You're going to have bleeding. You're going to have a lot of stools. You could have stools mixed with pus, blood, etc. On examination, it's pretty normal. Proctoscopy, you see a red velvet like mucosa. You definitely want to rule out hemorrhoids as well. Okay, and then you want to check for a very important MCQ point that is usually asked as fetal lactoferrin. So fetal lactoferrin is elevated in UC. That's ulcerative colitis. Now coming to the endoscopy of ulcerative colitis, as I already told you, it starts with the erythematous mucosa. It becomes edematous and friable, and then it becomes an ulcer, and after an ulcer it leads to regeneration, leading to a pseudopolyp, and that pseudopolyp is with a lot of fibrosis that is occurring. There is a lead pipe or a pipe stem appearance. Okay, and on that we have come up with a Mayo score because of this entire histological or endoscopic finding. We have come up with a Mayo score 1 2 3 1 2 3. 1 is when there is erythema, friability, and decreased vascularity. 2 is when there is friability, marked erythema, lack vascular pattern, and 3rd is the severe one when there is spontaneous bleeding and ulceration. Okay, so a very important complication of UC is that it can lead to toxic megacolon. That means because of this intense dilatation and lead pipe appearance, you have a megacolon that's more than 6 mm in size. Okay, you do your fecal lactoferrin or calprotectin, fecal calprotectin. It can come as an MCQ to check. It's the best diagnosis, but obviously you can do also your very important barium meal findings, and you can obviously see that you could see a granularity. You could see a lot of granularity, and you can see ulcers. You can see the lead pipe appearance itself on ulcerative colitis. Okay, so you can see hazy margins. You can see serrations on barium, because the mucosa is going to be having a lot of ulcers, and it's a continual involvement. You'll also have hazy margins, and you can, if it's reached the stage 3, you can see deep ulcers as well. Okay, they call the collar stud ulcers, or you could, and if it's the last stage, you could definitely see a lead pipe appearance. That's pretty basic. Okay, so that being a very important indicator, let's talk about Crohn disease. Okay, so Crohn disease, actually, what is the endoscopic finding in a Crohn disease? That's the question. Okay, the endoscopic finding in the Crohn disease is, as I told you, there's an ulcer. Okay, and that ulcer becomes into a rose thorn ulcer. Okay, it's seen as a rose thorn ulcer, and then becomes a serpentinous ulcer. Okay, a serpentinous ulcer, a snake-like ulcer, because they fuse ulcer, because of fusion, because they fuse. So let's say there are two ulcers that are present, they become serpentinous when they fuse. Okay, so that's about it. There's nothing very difficult. And then you have a cobblestone pattern. Just remember that there was a cobblestone pattern. And there's something called as on x-ray. On x-ray, what you can see on radio is that you can see a rose thorn sign, something called as a rose thorn sign, where you can actually see the transmural ulcers. You can also see a very important target appearance. Okay, where there's a lot of thickening of the colonic wall, and you can see a string sign because of the fibrosis of the terminal ileum. Okay, so string sign is also present out here in the Crohn's disease. So these are some important X-ray findings that I just wanted to name. I do not want you to understand every aspect of it, because that's again radio diagnosis that we are looking into. But a string sign could be seen because of the fibrosis can finally occur. So definitely you can see a string sign. Okay, what are the extra intestinal manifestations, if someone asks you? Well, it's simple. Okay, the extra intestinal manifestations in both the cases, okay, is it's seen in both the cases, but in some cases UD is common or UC is common compared to Crohn's. So let me just name a few cases where UC is particularly more common. Okay, otherwise in most of the cases Crohn's is most common. So pyoderma gangrenosum UC is more common. Similarly, PSC, primary sclerosing cholangitis, UC is more common. Okay, so these are two conditions where UC is more common. Now calcium stones, okay, calcium oxalate stones or cholelithiasis, nephrolithiasis is more common in Crohn's disease than UC, ulcerative colitis. So there are only two diseases that I spoke of, pyoderma gangrenosum and PSC, that are more common in USC. Okay, large joint migratory arthritis is more common in, again, Crohn disease. If you talk about aphthous ulcer, again more common in Crohn disease. Stomatitis, again more common in Crohn disease. Something like a pyoderma psoriasis gangrenosum, pyoderma granulonosum. As I told you, pyoderma granulonosum is more common in ulcerative colitis. That's it. Okay. Apart from that, erythema nodosum, I want to talk about erythema nodosum, is more common with Crohn's, but it's associated with prolapse. So prolapse, let me write prolapse next to it. So if there is a patient who has Crohn's or any of these and they have prolapse, okay, you want to think. Even LMAP is associated with prolapse. Now let's talk about the episcleritis or eye. Episcleritis is again associated with prolapse. So there's a patient with IBD and he has episcleritis. Okay, there is a very high chance of prolapse. Conjunctivitis, retinal vascular disease, scleritis, name it. Okay, ankylosing spondylitis. All right, name it. Spondylitis. It's again seronegative arthritis. As I told you, PSC, cholangiocarcinoma, autoimmune hepatitis, a lot of diseases. So these are the other diseases that can be involved with Crohn. But if I want to diagnose a Crohn, okay, how do I do it? You do a serology. And you can see an anti-Saccharomyces antibody. Saccharomyces cerevisiae antibody. ASCA. Another very important antibody that you can see is atypical P ANCA. But that is usually, I do not want to name atypical P ANCA already, so I'll name it later because that's something that is more common in ulcerative colitis. So first you talk about ASCA. ASCA is obviously seen, and it's also seen in a Beckett disease. It's again a vasculitis that's involving even the veins. So ASCA. Then you talk about anti-OMPC antibody, that's outer membrane protein citrulinated. Then you talk about anti-flagellin, okay? And I want you to remember anti-pancreatic antibody. Anti-pancreatic antibody. Okay. What next? Uh, if there is one more antibody that you really need to talk about is anti-I2. Okay, so that is something that correlates with surgery. So there are two important antibodies, anti-I2, ASCA, that I want you to understand. Okay, but when I'm talking about ulcerative colitis, I want you to understand P-ANCA, especially atypical P-ANCA, and also anti-goblet antibody. What are the complications that present with Crohn? Again, as you know, this side is ulcerative colitis, this side is Crohn. Sorry for destroying the entire setup. Ulcerative colitis, you have the complication simple. You have a toxic megacolon that I already spoke of. Okay, but what about Crohn? Obviously, because there's an ulcer, and this ulcer is not healing. It's a transmural ulcer, so you can have a fistula, you can have a fissure, you can have fibrosis, and the fibrosis itself is causing the string sign. Okay, fine. What about the dysplasia? Both of them can cause cancer or adenocarcinoma. Both of them. Okay. What about ulcerative colitis? It can cause cholangiocarcinoma. And Hodgkin's lymphoma can be caused by non-Hodgkin lymphoma. Sorry, can be caused by Crohn's disease. Now, once that's spoken about, let's do the treatment. The treatment, I'm not going to explain the entire regime. So I'm going to write 5-ASA is one part. Okay, that's amino salicylic acid. The other is steroids. Plus, you could add azathioprine. Okay, and in the end, you can do an anti-TNF alpha. Okay, antibody. So when it's a mild thing, it's a mild case, you just do 5-ASA. This is, I'm talking about ulcerative colitis, okay? And then if it's a moderate case, you want to add steroids, okay? And if there is no response, so you do an azathioprine, or you could do also 6-mercaptopurine, okay? And then you want to go for steroids and anti-TNF alpha. So instead of keeping azathioprine, remove that and you keep TNF alpha. Okay, you want to maintain it. Now you once treated the acute case, you want to maintain it. Again, you want to make sure that you give ASA in both cases of mild and moderate as well. And the moderate is going to remain the exact same. The moderate treatment is going to remain the exact same, where you again had 5-ASA and azathioprine, but just that you're not going to use steroids that early. If it's a severe case, you want to go for cyclosporin for maintenance. What about Crohn's disease? Crohn's disease, again, I'm going to just name a little bit. First, you go budesonide therapy, which is again a steroid, okay, and that's for mild. If you want to go for moderate, okay, mild, and moderate is going to be prednisolone. You want to make sure you give a prednisolone, and you also want to give methotrexate. After that, you could definitely you want to start an anti-TNF alpha, as it was the case in Crohn's as well. And then if it's severe, you want to go for anti-TNF alpha, and you want to make sure that the steroids are now IV steroids, okay? So that's very important, severe cases. And that is about the entire treatment plan as well about ulcerative colitis and Crohn's. So once we've spoken about all of this, let me just recap the entire thing with you again. Okay, so Crohn's disease, it can occur in any part. Ulcerative colitis, again, it's only in the colonic inflammation, usually the ileocolonic, and Crohn's is usually ileocolonic. Ulcerative colitis is pancolitis or rectal involvement. Transmural inflammation is seen in Crohn's and can lead to fistulas, cobblestone, creeping fat, as I've already said. Bowel wall thickening, string sign is also seen because of fibrosis. There is linear ulcers, fissures, serpiginous ulcers, aphthous ulcers. About Crohn's. Now let's talk about ulcerative colitis, mucosal, submucosal inflammation. Only the ulcers are shallow. They heal, and they heal with pseudopolyps. And lastly, you can have loss of hostra, which leads to lead pipe appearance. Microscopically, we see granulomas in Crohn's. We don't see granulomas in ulcerative colitis. We see cryptapsis in ulcerative colitis. In Crohn's, you see lymphoid aggregation. Bleeding is seen usually in ulcerative colitis. Okay. Now, complications that could be present. Both of them can show malabsorption, malnutrition, and cancers. But the ulcerative colitis leads to toxic megacolon, fulminant colitis, perforation. That's rarely. But the Crohn can lead to fistula, fissures, recurrent UTI, strictures, perianal disease. Intestinal manifestation can be diarrhea. Here there is bloody diarrhea in ulcerative colitis, as I've already said. Extraintestinal manifestation is almost the same, except that PSC is more common in ulcerative colitis. Okay, but kidney stones is more common, way more common in Crohn's disease. And you want to check for antibodies. Antibodies is ASCA positive, anti-I2, anti-OMPC, anti-pancreatic antibody. But here in ulcerative colitis, it's associated with MPO anchor or P anchor, atypical P anchor. Treatment is glucocorticoids for Crohn's. You want to make sure you can give an anti-TNF alpha. Also, you want to make sure you give a methotrexate. Okay. For ulcerative colitis, you keep in mind that you have to use 5-ASA. You can use 6-mercaptopurine, again azathioprine, and steroids, and again an anti-TNF alpha antibody. How do you want to diagnose your ulcerative colitis? Is that you want to use fecal calprotectin, okay, to diagnose your ulcerative colitis. Okay, any genetic disorders that are present, Turner, IPEX, that's present with ulcerative colitis. Okay, with Crohn's it's present. With Crohn's it's more of GSDs, Hermansky-Puktas syndrome, all of these. Okay, and microscopic colitis is another disease that we will see later.